Good afternoon, and welcome to the first 2022 Global Year for Translating Pain Knowledge to Practice webinar. I am Benjamin Farrell. I'm the coordinator of global programs here at IASP, and we're excited to bring you the first webinar of our global year. Today, we'll be hearing a presentation from Dr. Karin Faber on translating insights from genetic analysis in painful small fiber neuropathy into pharmacological practice. IASPs are thankful for everyone who could join us today and remind you that today's seminar will be recorded and available for later viewing at IASP's Pain Education Resource Center. I'd also like to encourage our viewers to utilize Zoom's Q&A feature to ask any questions you may have during today's proceedings. And during the webinar, I'd also like to reiterate and ask everybody to remain muted and cameras turned off just to avoid any distractions. At this time, I'd like to introduce you to our moderator for today's webinar, Dr. Heike Rittner. Dr. Rittner is a clinician scientist and professor at the Center of Interdisciplinary Pain Medicine at the University Hospital of Würzburg since 2008. She has published over 90 papers in peer-reviewed journals and received funds from German and European funding agencies. With that, I'd also like to thank you all again for joining, and I'm happy to pass today's proceedings over to Dr. Rittner, and I look forward to the webinar. Thank you, Dr. Rittner.
Yeah, thanks, Ben, for introducing me, and thanks especially to Karin to host our first webinar. I'm Heike Rittner. I'm a co-chair of the Global Year for this year, and we have the topic of translating pain knowledge into practice. Our aims are to increase the awareness of clinicians, scientists, and the public about the accumulating pain knowledge, and also bridge the gap between preclinical and clinical practices, and also raise awareness about challenges in designing new and more predictive preclinical studies and more effective clinical trials. And I'm especially glad and happy to have Karin today because she's presenting one of the stories that actually arose from animal models and also from studies in the culture dish to finally come to a clinical trial with a drug that can be used, and we're going to discuss in the future. And we not only have webinars, this is the first one of monthly webinars during this year, but you will also find on the homepage of the Global Year fact sheets about pain. We will present a seminar on the Pain Congress in Toronto, which I already invite you to. And we will have pain clinical updates in pain reports. And with this, I'd like to introduce Karin. Karin comes from actually quite close to where I'm living, from Maastricht. She is a professor in neuromuscular disorders and a medical director at the Maastricht University Medical Center. Has an extensive experience in the neuromuscular field. I found it very interesting that she really has specialized on sodium channelopathies, which will be the topic for today. And I also discovered that she has a very good skin biopsy lab and published lots of interesting papers on this. I thought this was actually cool. She's by training a neurologist. She trained in Groningen in the Netherlands and has been a neurologist since 2000, and an associate professor and then full professor since 2014. And I already told you she published many papers. Some of them I also discovered during the last couple of days and found very interesting. And I'm very glad that she's going to present the story of sodium channelopathy, small fiber neuropathy, and Lacosamide. And we asked Karin also to have the seminar not only understandable for scientists, but also for normal people. So I'm actually looking forward because I already peeked into this talk, and it's going to be really exciting. So thanks for doing this, and thanks for doing the first one.
Thank you very much, Heike, for your very kind words. I must say I'm very honored to be invited to give this first webinar. And I'm also happy to do this because it's not only something that's from the bedside to the lab and back, but it also shows that collaboration among many centers was really mandatory for this success. So it's not only our success, but it's a success of an entire group of scientists working together all over the world. And I think that's also an important lesson that we should learn. We cannot do anything on our own, I think. Regarding conflicts of interest, well, we have received grants for research from the European Union, from the Princess Beatrix Spear Funds and Neuromuscular Foundation, from companies for the trial on small fiber neuropathy, but that was on IVIG, not on this one, and from the EU. As you all may know, pain is described as an unpleasant sensory and emotional experience associated with actual and potential tissue damage. And neuropathic pain is pain caused by a lesion or disease of the somatosensory nervous system. And that brings us to small fiber neuropathy, which is a neuropathy that exclusively or mainly involves the small nerve fibers and thereby leads to painful sensations. These small nerve fibers are the A delta and the C fibers, and these are thinly myelinated E delta fibers and unmyelinated C fibers. And this leads to sensory symptoms, often neuropathic pain characterized by burning, but also stabbing or sharp pain, predominantly in a length-dependent pattern. Also, an alternative distribution of pain may occur, meaning that it can be patchy or more proximal. Furthermore, there may be abnormalities in pain and temperature sensation, and patients may experience autonomic complaints, such as palpitations, diarrhea, flushing, and orthostatic complaints. As I said, usually the pattern is length dependent, meaning that the complaints are more dominant in the extremities, but occasionally you can have different patterns, meaning patchy or more proximal pain. We have several diagnostic tools available, of which quantification of small nerve fibers is the most important. Worldwide normative values have been developed and are used to determine the lower limit of normal. And the yellow ones, here you see the nerve fibers crossing the basal lamina of the skin biopsy. What we also do is using quantitative sensory testing and especially temperature thresholds. This can be helpful to determine the function of the small nerve fibers, as these play a role specifically in temperature sensation. Because this test is not specific, it needs to be judged in the context of the clinical picture, and you cannot use it as a diagnostic test on its own. And that's very important to realize. Therefore, the diagnosis of small fiber neuropathy requires a clinical picture, usually complaints of burning pain and hyperalgesia and or allodynia on neurological examination in combination with one or more abnormal diagnostic tests. As we have learned from our own region, small fiber neuropathy is not very rare. We found a minimum prevalence of 53 per 100,000 inhabitants, and this really is a minimum prevalence. It may be higher. And it is very important to realize that quality of life in these patients is severely reduced, both in the physical as well as in the mental component scores. And these scores are comparable to other severe illnesses, like, for example, stroke. We therefore should take this condition very seriously. Small fiber neuropathy may be associated with many other conditions. And numerous causes are present in literature, and we have therefore performed a large study to determine which underlying conditions are most prevalent in our population. And what we have found in a population of 921 patients is that the most frequent associated conditions were immunological abnormalities or conditions, diabetes and glucose intolerance, and vitamin B12 deficiency. In patients who were already known with a possible underlying condition at screening, additional underlying conditions were still found in another 27% of patients. And over 50% of patients were considered idiopathic. The fact that you can find underlying conditions in patients that already have an underlying condition means that you still have to screen for other underlying conditions. You cannot say, well, this patient has diabetes, so there's no need to check for other conditions. In the past years, it has become clear that variants in sodium channels may play a role in the pathogenesis of small fiber neuropathy. At first, we found gain-of-function variants in the SCN9A gene, the gene that encodes for NEF1.7, and later also in NEF1.8 and NEF1.9. And among 1,139 patients with small fiber neuropathy that were seen in our center between 2009 and 2017, 132, which means almost 12%, harbored 73 different potentially pathogenic voltage-gated sodium channel variants, of which 50 were novel and 22 were found in more than one patient. And the frequency of variants in SCN9A were 5.1% in this patient group. Or as they say, for the SCN10A, it was 3.7%, and for SCN11A, it was 2.9%. One of the questions, of course, is whether patients harboring voltage-gated sodium channel variants have a specific phenotype. We have compared this for several clinical characteristics, such as quantitative sensory testing, nerve fiber density, abnormalities at neurological examination, complaints, but also several questionnaires, such as the small fiber neuropathy symptom inventory questionnaire and a neuropathic pain scale. And as you can see here, only erythromelalgia-like symptoms and warmth-induced pain were significantly more common in patients harboring voltage-gated sodium channels. We've done the same to compare the clinical characteristics of variants in SCN9A, SCN10A, and 11A, and only erythromelalgia-like symptoms are present more frequently in SCN9A. The function of wild-type sodium channels and of channels with a certain variant can be investigated by means of electrophysiological studies, patch clamp analysis. And this brings us to our collaboration with the team of Steve Waxman and Suleiman Dibhaj and Yale University, who have performed this analysis for us. In patch clamp analysis, we are able to investigate the channel function by voltage clamp analysis. This provides information about depolarization, inactivation, and repolarization of the channel. Using current clamp studies, information can be obtained about channel excitability, such as the resting membrane potential, the current threshold, spontaneous firing, and firing frequency. And you can see that these studies are complementary. And what we have seen in the patch clamp analysis is that many of these variants have an impaired slow inactivation with a resting membrane potential depolarization, a reduced current threshold, an increased firing frequency, and increased spontaneous firing. The next question we had, of course, was, does this increased firing and spontaneous firing lead to axonal integrity problems? And therefore, a study was performed also in Yale University, and we compared the neurite length of neurons expressing the sodium channel variants 1228M, a combined mutation, and the I720K, and of course the wild type variants. There was a reduced neurite length of the I228M transfected neuron compared to wild type. The other two mutations show a trend towards reduced neurite length. After that, we investigated whether a sodium channel blocker would affect the increase or the growth of these neurites. And the cultures were treated with the sodium channel blocker carbamazepine. And after 3 days, the neurites with I228M exhibited an increased neurite length compared to untreated neurons and approaching the length of wild type expressing neurons. This effect was not seen in the treated wild type neurons. Increased axonal sodium influx has been shown to trigger reverse operation of the sodium-calcium exchanger, producing intra-axonal overload and axonal dysfunction. Therefore, cultures were treated with a blocker of this sodium-calcium exchanger, and this inhibits reverse but not the forward operation of the exchanger. Following 3 days of treatment, transfected neurons exhibited substantially longer neurites compared to untreated cells. So therefore, the sodium channel mutations may lead to reduced axonal integrity, and in vitro, this may be prevented by treatments, either by blocking these sodium channels or by influencing the harmful calcium influx. Also, in a special mutation that we found, we demonstrated that metabolic stress and depolarization elicit neurite degeneration. This was seen in the G856D variant. And this is also important to realize. Well, the next question is, how do we treat patients with small fiber neuropathy? And the current treatment is only effective in half of the patients with a maximum reduction of 50% of pain. And given the high burden and the huge influence on quality of life, there is an unmet clinical need. Besides this, side effects are very frequent, often leading to discontinuation of drugs. And given the often disappointing results of currently available drugs, there is the need for personalized treatment, and the unraveling of the genetic pathways in small fiber neuropathy may be the gateway to this development. The more targeted the therapy, the better the result that can be expected. In case of sodium channel mutations, the sodium channel seems the perfect target. Moreover, voltage-gated sodium channels play a key role in the generation of pain, and therefore proving the efficacy of a sodium channel blocker in patients with NaV1.7 related small fiber neuropathy may also be beneficial for other patients with neuropathic pain. Lacosamide is an anticonvulsant drug, a functionalized amino acid molecule that selectively enhances the slow inactivation of voltage-gated sodium channels and interacts with the collapsin response mediator protein. It differs from other sodium channel blockers because of its unique mechanism of action. It inhibits the currents of hyperexcitable neurons of the voltage-gated sodium channels by targeting the slow inactivation state and sparing channels with normal activity. Recently, it was also suggested that lacosamide binds to the fast inactivated state of NaV1.7, but at a slower rate. Furthermore, lacosamide has been found to have a higher affinity for tetrodotoxin-sensitive sodium channels over other ion channels and central receptors. Therefore, we decided to perform a randomized, placebo-controlled, double-blind, crossover design study in patients with small fiber neuropathy related to NaV1.7 mutations. During both of the two phases, the subjects were treated for a period of 8 weeks with 200 milligrams lacosamide twice daily or placebo, preceded by a titration period and ending by a tapering period. The patients filled in a pain diary twice daily and scored a set of validated questionnaires on autonomic symptoms, sleep interference, and quality of life at multiple study visits. As you can see, the main weekly average pain score was lower during treatment with lacosamide compared to placebo. So lacosamide is the red dots and placebo are the blue dots. And also, we saw that besides the effect on pain, also the patient global impression of change very much improved or much improved was higher, 40% in lacosamide versus 12% in placebo. So we can conclude that neuropathic pain is a common feature of peripheral neuropathies, especially in small fiber neuropathy. And there is an important role for voltage-gated sodium channel mutations in these patient groups. And gene mutations have been the key to targeted treatments in our study. The next step was that we moved back to the basic science again, because we wanted to explain why some patients reacted and some patients did not react on lacosamide, because not all patients had a good effect. And this was also performed by the lab of Steve Waxman and Suleiman Deebhaj in a study performed by Julie Labau and colleagues. And they used voltage clamp recording to evaluate the effects of lacosamide on 5 NaV1.7 variants from patients who were responsive or non-responsive to treatment. And in this figure, you can see the clinical responses for each variant. The response from a non-responder, the I228M, the green stripes, and with a large clinical response, that is D, and the responses from the patients carrying the I739 variants, 5 patients, of whom 4 were responders, and responses from patients carrying the L1267 variant, 4 patients, of whom were 3 non-responders. And you can see that lacosamide affects the slow inactivation for each NaV1.7 variant. Lacosamide significantly enhanced the slow inactivation in wild type and all mutant channels, except for the W1538R. And lacosamide effects on steady state fast inactivation. As you can see, the fast inactivation was only affected by lacosamide in C and in D. And you can see that it has an effect on the use-dependent block for each NaV1.7 variant. And you can see these, oh, I moved too fast. So in conclusion, we can say that lacosamide acts as a potent sodium channel inhibitor of NaV1.7 variants carried by responsive patients. Hyperpolarizing shift of voltage dependence of both fast and slow inactivation and enhancement of use-dependent inhibition. Lacosamide selectively enhances fast inactivation only in variants from responders. So while fast inactivation seems to be the parameter that discriminates the responders from the non-responders, the effects of lacosamide on slow inactivation and use dependence might also be required for complete and sustained pain relief. The W1538 residue is necessary for the initial binding of lacosamide to the NaV1.7 channel, facilitating its access to the channel's pore at therapeutic concentrations, and differs from traditional anti-epileptic drugs. So this was also shown in a very nice study of Julie Dabau and colleagues. So the take-home message of all these studies are that small fiber neuropathy is a painful neuropathy selectively involving the small nerve fibers, A delta and C fibers. Typical clinical signs are required to establish the diagnosis, and skin biopsy and quantitative sensory testing are confirmatory diagnostic tests. Small fiber neuropathy has a severe impact on quality of life, and current therapeutic options are generally insufficient. Voltage-gated sodium channel mutations play an important role in the pathophysiology of small fiber neuropathy. And these gene mutations were the key to the development of targeted treatment and may be the key of further developments as more selective sodium channel blockers are being developed. As I already said in my introduction, this work cannot be done alone, of course. And I have a lot of colleagues from Maastricht University who are working together with me, of whom I specifically want to mention Janneke Hoeimakers, Ingemar Merkies, Bert Smeets, and Monique Gerrits. Of course, the lab in Yale, Stephen Waxman, Suleiman Deep Hatch and his team, and the team in Carlo Besta Institute, Giuseppe Lauria and his team. Thank you very much for your attention.
Yeah, Karin, thank you very much for this concise and I think nicely explained study and the story of the last couple of years. So I'd like to encourage everybody again to ask questions and to put this in the Q&A. Push the Q&A button and then I think it pops up. We have enough time to discuss, which is actually great. And there was already one question that I would like to start with. And one person from our audience asked, why are the small fibers affected selectively or first or most, and not the sensory or the autonomic fibers? Maybe you can comment on this.
Well, I think that's a very good question. Well, we know that the NaV1.7 is highly present in small fibers. So that's why we assume that these fibers are more selectively involved in small fiber neuropathy, in sodium channel related neuropathy. But for many other neuropathies, for many other small fiber neuropathies, so meaning other causes, we don't exactly know why some people develop a small fiber neuropathy, while other people develop a large fiber neuropathy. So that's really, well, we don't know at this point.
Okay. Well, at the moment there are no other questions. So I'd like maybe to ask one that I asked myself. I wasn't quite sure, or I think I missed this, why you came up with Lacosamide, because as I remember, this was initially designed to be a drug for treatment of epilepsy. And then I think there were some trials in diabetic, and in the end, it was not successful. So why did you pick this drug, and what's the difference between the two diseases, or just comment on this?
Yeah, well, that's a very good question. Once we had found the relation between sodium channel mutations and small fiber neuropathy, of course, we wanted to do something for our patients. We wanted to treat them. And at that point, there was a selective sodium channel blocker in development. And this was the initial idea, to treat patients with this sodium channel blocker. but that development was stopped. And at that point we said, well, then we need something else. And we started studying literature and found that lacosamide was a sodium channel blocker. Of course, there are other sodium channel blockers, like, for example, carbamazepine, but that's not so selective. And we really needed a selective sodium channel blocker because the side effects of carbamazepine are, well, numerous. So that's the way we did not want to go. And that's how we came up with lacosamide and decided to try this. And despite, well, the efficacy in diabetes was there, but it was not very rigorous, I think. But especially the company was not very interested in trying lacosamide in the treatment of pain. We tried to, well, to ask them to be involved in the study, but they were not interested. Mm-hmm. But then we decided to move on just by ourselves, and we managed.
Yeah, and I think it's, I really have to commend you on this, because doing this as an investigator-based study is a lot of effort, and I think it really moved the field forward to do this. I have more questions on the lacosamide. The next question is, what dose would you start with? Because I think you used 200 as a total daily dose, but yeah, I think you can also use higher dosages. Maybe you can.
Yeah, if you use higher dosages, you have more side effects. So that's why we ended up with this dose, and we have a step up treatment, and I think you can find it in the protocol, and the protocol is described in trials, so you can also find it there exactly how we did it.
Okay. And are you still using it for your patients, or?
Yeah, we use it if we have patients that are not reacting on the more regular medication. We do it. Yes.
Mm-hmm. And there was another question: are there SCN11 variants also a risk factor for painful or painless polyneuropathy, IAG, for example, in diabetes or chemotherapy induced neuropathy?
Yes, we have performed a multi-center European study also in diabetes, and we found also in diabetic painful neuropathy mutations in NaV1.7, NaV1.8, and NaV1.9. Mm-hmm. So also in these painful neuropathy, we found this. For painful chemotherapy-induced polyneuropathy, I'm not aware of a large study that has been done. So at this point, we don't know. But it may be that patients with mutations are more prone to develop painful chemotherapy-induced neuropathy, and therefore it would be interesting to start a study on this, because it may influence your treatment strategy.
Mm-hmm. That's another question. Do you think phenytoin as a non-selective sodium channel blocker might also be effective in small fiber neuropathy caused by NaV1.7 or NaV1.8 mutation?
Well, we did not try it exactly because what I said of carbamazepine, it is very non-selective. So you need high doses to treat pain with a lot of side effects. So, and also because phenytoin is not a drug you want to use on a chronic basis. So I would not advise that.
Yeah. Okay. Okay, and then there's a question from a completely different angle. Can physical therapy help these patients, or other therapy options? Yeah, what do you think? What do you do?
Yeah, I think that that chronic pain also in small fiber neuropathy is a multimodal condition that needs multimodal treatment. So yes, physical therapy, but also psychosocial interactions may be very important. So it's not only drugs, but I think you need really a multimodal treatment for these patients.
Yeah, I'd like to comment on this as well, because we also have a pain clinic in Würzburg, and we do have, I mean, it's not all of our patients have small fiber neuropathy, most of them have back pain, but sometimes we do have them, and I think we need more. And I also like the occupational therapy or the desensitization, just to train the brain for something else. Let's put it this way.
Yeah, that's true.
The next question is, there was a compound called bixotrigine in development, is a selective sodium channel blocker. Have you came across it?
Yes, we have participated in the trial. And
we have the expert.
And there will be a poster on EFIC, I think, of this drug. So the paper is in preparation.
Oh, okay. Okay, so that's good. We can advertise the World Congress of Pain, which will be, a congress. I think at least my first big one in the pandemic, and keep our fingers crossed. Nothing gets worse. Many of the small fiber symptoms are similar to CRPS. Is there any proven or suspected link in this point? That's a good question. Interesting.
It's a very good question. There is no proven link at this point, but we have also noted that many symptoms seem similar. There are also some differences, I think. So, but it would be very interesting to do more research on this as well, because many causes on CRPS are still unsolved, I think.
This is true, but then on the other hand, usually patients, they really complain about the pain in one extremity. I mean, we had one paper where we said, okay, in cases where the disease is quite severe, then also the other side shows some abnormalities in the QST, but I still think it's somewhat different, but definitely it will be worth looking into it, whether there are any mutations. I don't think this has been done, so maybe we should send you some samples from us.
Yeah.
Okay. Can small fiber neuropathy induced by chemotherapy be reversible? Is another question.
Yeah, it depends a bit on the drug, but it can certainly be reversible. Yeah.
Yeah, I think that's, it also depends, I think, when it's actually stopped, and also depends on the severity of the symptoms. Are certain sodium channel mutations more prevalent in patients with specific conditions associated with small fiber neuropathy, for example, diabetes or PHN? Diabetes we already touched on, and PHN, I'm not quite sure what this is. Maybe the person.
Painful.
Okay.
Painful.
Maybe we come back to these questions. There's another question. It seemed that sodium channel mutations did not cause small fiber neuropathy in one of your studies. Does that mean that pain due to the sodium channel mutations may not be related to nerve degeneration? Does that change? Who should get this treatment? Also, does the possible point to other mechanisms of small fiber damage? I think that goes into the questions of
Yeah, I can answer that, I think. I mean, it is, of course, whether we say that the sodium channel mutations are a risk factor or part of a combinational model or a multi-hit model, I mean, that's terminological. The point is that under the right conditions, as has been shown with the metabolic change and depolarization, it contributes to or causes axonal degeneration. And I think that's really important to realize. And also the other studies that have been done in Yale show that it contributes to, decreased neurite outgrowth. So there certainly is an effect on neurite integrity. And we suspect there is a link, but you cannot say it is the cause of the small fiber neuropathy. I mean, that would be too harsh, I think, but it certainly contributes. And
why do you think is the degeneration or the reduced outgrowth, why does that hurt? Or what's the concept there?
Yeah, that's indeed a very good question. That's also what we wondered for example, for diabetic neuropathy or other small fiber neuropathies. So that's not specific for the sodium channel related small fiber neuropathy. It's for small fiber neuropathy in general that you have a decreased number of nerve fibers or even zero fibers, and you have an increase in pain. And that's something we cannot really explain very well.
Do you think we're looking at the wrong fibers? That maybe, or the degenerated fibers express something that we can't really.
I don't think so. What we do know is that in patients with this sodium channel related small fiber neuropathy, we do see increased firing, and that's compatible with pain, but we don't know why this is.
Yeah, this is true.
And
yeah. One person from the audience was asked whether you do genetic tests before starting it. This was yes, right? Or
yeah, we do genetic testing in all our patients because of course we
whoever walks in. So would you recommend?
Yeah, I mean, it's very difficult. We tested this in patients with sodium channel related small fiber neuropathy. So that's what we did. And it's a small study. So I think you cannot say this is a proven therapy, as to say. It's more like a proof of concept study. But of course, if you have tried everything else and it doesn't work, you can try it. I mean, it's a drug that is on the market. It's not extremely expensive. It has not very severe side effects. So I don't think you do a lot of harm with that.
But would you in the future recommend to do genetic testing on your patients before you start with this? I mean, I'm not really treating these patients extensively, but I thought it would be cool. I'll send you the genetics and you tell me, okay, that's the mutant and that should work. And then we'll go for it. What do you think?
Yeah, well, as said, we do the genetic testing in all our patients because we really want to know whether they have mutations or not mutations. And patients also want to know because they want to know what is the cause of my condition or what contributes to my condition. But I can imagine that it's not possible everywhere because it's also quite expensive. And I think that for small fiber neuropathy, if you don't have a clue to what causes it, well, there is no evidence at this point that lacosamide has an efficacy because we did not test it. It doesn't mean it doesn't work, but we don't know yet. So I would not widely recommend it, but it's not that you do something wrong if you try it. If you are at the end of your therapeutic strategies, you of course may try it, but realize that there's no proof.
Yeah, and would you apply this also topically? If I don't even know, that was one of the questions.
Yeah,
or is it possible?
I don't know if it's possible. I don't think so. I know there are topical therapies, but I don't know that lacosamide is one of them.
On the other hand, if you apply local anesthetics, it's not doing much. So maybe not.
No.
But that's like, how sustained is the response to lacosamide in patients with small fiber neuropathy?
Yeah, our trial was for a limited period of time, but after that, some of these patients have continued lacosamide and are still very satisfied. But as said, we have responders and we have non-responders, of course.
Okay. And do you think that it would also work in ischemic neuropathy?
I really don't know.
I think so. I don't think so too. Yeah, there's the question of the topical mode is coming up again. Or does the drug need to also act on the CNS for pain relief? I don't even know. Does it cross the blood-brain barrier or the blood-spinal cord barrier?
Yes, it does, because it's also an anti-epileptic active drug. So,
it has to be, yeah. But this has not been tested. I mean, one could test this in animals, whether you need the central part as well or you don't. But this hasn't been done, right?
No.
Okay. Many questions. PH.
That's good.
Post-herpetic neuralgia.
Ah, yeah.
Yes, sorry. So are certain pain patients or subpopulations more likely to respond to lacosamide if they have one comorbidity or a different one? Would you, yeah, I think it's a comment on comorbidities. Are there comorbidities where you wouldn't give it or where you would give it? Let's put it this way.
No, well, I don't know. It was safe and the side effects were manageable.
Mhm.
So I don't think that there are really very comorbidities that would really prevent it from giving it. But well, we did not test it in for example, post-herpetic neuralgia. So I really have no idea whether it works there.
Yeah, it's probably also off-label. So, well, it will be off-label anyhow, but yeah. From a CRPS patient and advocate in Montreal with a background in bioethics. I'm not quite sure what the question is. Okay, sorry, but hello to Montreal. I have studied the level of micronutrients among pain patients and noticed that small fiber neuropathy patients do have shortages of various micronutrients. A supplementation has, to my experience, helped many patients together with an anti-inflammatory or Mediterranean diet. Comment, please. I'm not quite sure what micronutrients are, and sometimes it's a pity that we can't have our audience to join in and explain something, but maybe you know.
I don't know, so that was what I would ask. What kind of micronutrients is it? Is it something we can measure? Because we know that, for example, vitamin B12 deficiency was among the most common causes or related conditions, but in other patients, well, supplementation of B12, for example, did not have any effect.
Yeah, I think it's clarified here, vitamins and minerals. I'm not sure whether there's any evidence on this.
Well, B12, there is evidence from our study, but not from other minerals. We did not test that.
Okay.
So I don't know.
And here's a good question that I also wanted to know. In your study, did you test for, psychiatric comorbidity and also the improvement of symptoms in terms of depressive symptoms or anxiety or stress or something like that?
Yeah, what we do in our standard evaluation of patients is the HAT score, so depression and anxiety testing. And indeed, as you can expect in patients with chronic pain, they have increased scores, of course, on anxiety and depression. But we did not test whether that was influenced by the treatment of lacosamide. I mean, I think the study was too short to have a really robust effect on that.
Yeah, I would also think so, because when we do we treat patients with multimodal therapy, and they always have a long history of pain. And that's also one of my questions. I mean, these patients, they probably had small fiber neuropathy for some time. And that's nothing that you reverse in 4 weeks.
No, exactly.
So you need more time and probably some other treatments. What's the prevalence of sodium channel variants in normal population, i.g., for example, in people with no neuropathic pain?
Yeah, it depends on what you define as a variant. But as the variants that we describe are variants that have a very low prevalence, because otherwise they're not very likely related to the condition of interest. So they have a very low prevalence.
Okay. And then was a question about fibromyalgia and myalgic encephalomyelitis. Are they components of small fiber neuropathy? What's your thought?
Well, I don't know. There have been studies, I think, from Würzburg as well, that the small fiber neuropathies may be affected in fibromyalgia, or, well, we don't know. It can also be that some patients with small fiber neuropathy are mistaken for fibromyalgia because, well, it's a difficult condition to diagnose, I think. I think that it really needs more research to have a good answer on this question, because we don't know at this point.
And I think the last question before we summarize and finish our session is the autonomous sympathetic system an important factor in pain for small fiber neuropathy, and could radiofrequency treatment play a role? So I think the sympathetic, is there anything on the sympathetic system in small fiber neuropathy?
Well, what we see, patient can have autonomic symptoms like dizziness, palpitations, etc., diarrhea, but I have no experience with radiofrequency treatment, so I'm not sure what is meant with that.
I don't also know. Okay. Okay, and with this, I would like to thank the audience for many, many questions. I think I learned today that it does make sense to do genetic testing and to explore specific drugs. And I'm quite encouraged to go forward with my research, and also what you guys are doing and what you guys are going to bring up in the future. And I loved a lot that you actually went back from the clinical trial to the lab again and see, okay, why do some patients react and why they don't? So this back translation, I think, was very exciting, and I'm encouraging all researchers and clinicians to go ahead. And if you did something and you don't know why it was that way, then just go back to the lab and find out why it is.
Yeah.
With this, I think I'm going to hand back to Ben for a final farewell.
Yes. Well, a final thank you to Dr. Faber, your fantastic presentation, and again, Dr. Rittner, for your moderation and that excellent Q&A. As a reminder, this webinar will be uploaded to IASAP's Pain Education Resource Center for viewing. And again, an additional thank you to all of you for attending. Thank you.
Thank you.